Well, this afternoon session is very useful because it really emphasizes that there is a lot more to prevention and management of thrombosis than medications alone. And I think we also have to work on the communication with our clinician. And in the tradition of the Passover Seder, there are four key questions. First, why am I being anticoagulated? Second, what are the risks versus the benefits? Third, how did you, the clinician, select the anticoagulant? What about the debate we had this morning at the Thrombosis Summit? Should it be warfarin or one of the novel oral anticoagulants? And if a novel agent, which one? And then how long should I be anticoagulated? And the major indications for anticoagulation would be stroke prevention in atrial fibrillation, treatment of pulmonary embolism or DVT, and mechanical heart valves. So we're always weighing the risks versus the benefits. And with warfarin, there is a substantial risk of bleeding even if we have the INR within the desired therapeutic range. Aside from bleeding, there are less well-known adverse effects: hair loss, coronary calcification, osteoporosis. And at this point, I'm convinced from having talked to probably thousands of patients that there is often a fatigue or a cold feeling that persists. I have to point out some of the potential dangers with warfarin, particularly in adults 65 years or over. Major adverse events with warfarin account for 46% of visits to the emergency department, more than any other drug, more than insulin or the antiplatelet agents or the oral hypoglycemic agents, and that when these patients on warfarin visit the emergency department, about a third of them end up getting hospitalized because of an adverse event related to warfarin. Now, the benefits of warfarin are that it has stood the test of time, and there are ways to reverse its effect with vitamin K or fresh frozen plasma or prothrombin complex concentrates. The level is readily measurable with the INR. It's inexpensive. And one thing that patients cherish is that personalized interaction with the pharmacist or nurse if they are managed by an anticoagulation management service. We spoke this morning in detail about the novel oral anticoagulants. Dabigatran and rivaroxaban have already been FDA approved for various indications. Apixaban will probably get approved within the next year for stroke prevention and atrial fibrillation. And if I had to take an educated guess, edoxaban might get approved 2 years from now for stroke prevention and atrial fibrillation. And the new anticoagulants, like any new medication, do not have a decades-long track record. For the moment, there's no specific antidote, though I do think there will be specific reversal agents within the next several years. And drug levels at the moment cannot be measured, but that's also going to change within the next few years. And it's important to know that most of the novel agents are cleared by the kidneys, so that a deterioration in renal function may predispose to bleeding. Now, the benefits are of the novel agents compared with warfarin: equivalent or superior stroke prevention, fewer intracranial bleeds, immediate onset of action and a short half-life, so there's no need to have bridging with low molecular weight heparin. They're given in fixed doses, so they're convenient. There's no laboratory monitoring, making them even more convenient. And important to what Mark was talking about, there are minimal drug-food interactions. So you want to eat all those high vitamin K foods, be my guest, you can do it. And then, Mark, you find out who really wanted the vitamin K food after they've been switched to from warfarin to dabigatran or rivaroxaban. So a question I think is fair to ask your clinician. If you're taking warfarin, should you switch to a new agent? And I think if it's an easy yes, if there's been a bleeding or clotting problem on warfarin. You know, one guiding principle we have in the practice of medicine is if something hasn't worked, we try something else. So we don't like to go back to something that's been a strategy that's been a proven loser. Until the new anticoagulants came along, we were really constrained because we didn't have many options, but now we do. I think answering this question is more challenging if all is going well, because there tends to be a feeling of let's not rock the boat. But on the other hand, if one wants to take cold calculations, across the board, with the new agents, there is less major bleeding and certainly a tendency for fewer strokes if you have underlying atrial fibrillation. The new CHEST guidelines published this year recommend the novel oral anticoagulants over warfarin. Okay, that's from the American College of Chest Physicians. And for treatment of acute DVT or pulmonary embolism, though rivaroxaban is not yet FDA approved, the CHEST guidelines are ahead of the ball, so to speak, and recommend either standard anticoagulation or anticoagulation with rivaroxaban as monotherapy, meaning that you never have to be injected at all with any anticoagulant for treatment of acute DVT or acute pulmonary embolism if you receive rivaroxaban. And then the question comes up about how long should one be anticoagulated. If it's for stroke prevention and atrial fibrillation, almost always we're talking about lifelong anticoagulation because the risk of stroke would otherwise increase with age. And of course, with mechanical heart valve, it's lifelong anticoagulation. What we see here is that after anticoagulation is discontinued for patients with DVT or pulmonary embolism, there is a surprisingly high rate of a recurrent DVT or pulmonary embolism. If you follow patients 10 years off anticoagulants after a 6-month period of anticoagulation for pulmonary embolism or DVT, and if there was no inciting reason for the clot to begin with, it turns out that the recurrence rate is a whopping 50% over 10 years, a 1 out of 2 chance of a recurrence. And if the DVT or pulmonary embolism occurred in the setting of pregnancy or birth control pills or in the setting of a surgical procedure, after stopping anticoagulation over the next 10 years, the likelihood of a recurrence is about 20%. And the CHEST guidelines from 2012 state that if provoked by surgery or non-surgical transient risk factor, anticoagulate for 3 months, though many of us as practitioners anticoagulate our patients for longer than that. And if it's an unprovoked idiopathic or primary pulmonary embolism or DVT, the guidelines suggest extended anticoagulation, particularly if the patient is at low to moderate risk of bleeding. Now, in many patients, it turns out that it's hard to determine whether the DVT or pulmonary embolism is provoked or unprovoked. These patients fall into the gray zone. And here, we get the art of medicine superimposed upon the science of medicine, and we have to consider the past medical history and the family history of DVT and pulmonary embolism, gender, because for reasons we don't understand, men are more predisposed to recurrence than women. Failure to recanalize the leg veins in ultrasound means that there's a higher risk of recurrence after anticoagulation is discontinued. Certain types of hypercoagulability predisposed to recurrence. And of course, patient preference. You know, it's been said that we as clinicians guide, but that the patient decides. So I think in terms of maintaining the best possible cardiovascular wellness, it's a good idea to take the prescribed medications as directed. And this afternoon, we've been reminded about the benefits of daily exercise for at least 30 minutes a day, 6 to 7 days a week. Mark just gave us a great talk on heart-healthy nutrition. And with these factors in mind, plus or minus a statin, our patients can generally achieve an excellent lipid profile, and we can prevent many cases of diabetes and the metabolic syndrome with heart-healthy living. Finally, I want to point out some reliable sources of medical information because there are many unreliable sources. Reliable sources can be found on Medscape, theheart.org, and our beautifully just launched new NATF website. In conclusion, ask your clinician the important questions. Understand why you're taking anticoagulants. Ask specifically about the novel anticoagulants, realizing that most of the major guideline writing committees, whether they're in America or Canada, or most recently in Europe at the European Society of Cardiology meeting in Munich a week and a half ago, are all shifting over to recommending the novel anticoagulants as the best option. Understand the issues related to the recommended duration of anticoagulation therapy and embrace the concept of cardiovascular wellness. Thank you very much.
Sam, that was fantastic, and I'd like to open it up to the audience because I think they'll be eager to ask you questions now that you've offered.
Actually, two quick questions. Maybe you can clarify bridging, particularly with low molecular weight heparins, for the treatment of VTE. Once a day is pharmacoeconomics, 1.5 milligrams per kilo. Do we have to do twice a day, or what is the recommendation on that bridging regimen?
Okay, so let me repeat that question and paraphrase it a bit and go beyond the question. First of all, I think in general there's far too much bridging going on because patients who've had, for instance, a DVT or pulmonary embolism, generally speaking, after 3 months of anticoagulation should not be bridged unless there's some other extreme risk factor for clotting. And the majority of patients with atrial fibrillation at the moment should not be bridged either. If they've had a stroke, then of course it's a different story and they should be bridged. In general, of course, with the novel oral anticoagulant, there's no need for bridging whatsoever. You just omit 1 or 2 days of the novel oral anticoagulant. which is a great advantage. If you have a patient on warfarin, we would generally bridge with once daily low molecular weight heparin. The doses that you were talking about dealt specifically with enoxaparin, or Lovenox, which is one of the low molecular weight heparins. We would generally go with once a day prescription. But you have to be careful because studies show that in many instances the bridging causes a lot more bleeding than preventing of new thrombotic events.
The second question is, the new guidelines recommend taking that total daily dose, where the bridging was Q12 previously, and giving that all up front.
I'm not sure what guidelines you're referring to.
The new CHEST guidelines for the treatment.
Recommend taking the total...
Yeah, so typically in bridging, it's a milligram per kilogram Q12 enoxaparin. Mm-hmm. They recommend now giving that all up front. So 100 milligrams twice a day would now be 200 milligrams once a day. And I think this was a 1B. I don't remember the class recommendation.
Yeah. Well, I would never. That's a guideline I would not follow, because I think if you're giving someone 200 milligrams of enoxaparin, they're very susceptible to a major bleeding complication.
That's where we are. Yeah.
Yeah.
Thank you.
Excellent. That was fantastic.